ladies and gentlemen. Wish you a good appetite. What did we learn from nutrition monitoring? I think what we learned is that we could do a much better job. And I have to declare some potential conflicts of interest, as usual. Is that better now? Yeah. Okay. So, monitoring nutrition is different. And what is so different from monitoring some other activities we do in the ICU? If you look at hemodynamics, that's quite easy. You can monitor blood pressure, cardiac output, whatever you want. You can deliver a drug, inotrope, vasoconstrictor, and you look at the effect. And then you see, okay, that's my effect. It works or it doesn't work. You can change the drug. So that's quite easy. That's what we do every day. But now, how is that with nutrition? Obviously, you can also monitor the compound you deliver, but how is it with the effect? What is the effect of enteral nutrition? How do you measure that? How do you monitor that? And what are the side effects? Not even if there is intolerance of enteral nutrition, you could surely say that this is a side effect. Could also be just that the disease now shows up when you try to do something with the gut. So, if we can't measure what we actually do, how do you know what products we should administer? And this is just one study per chance, and you see that usually in all these studies, you screen hundreds or thousands of patients, and then you include just a minority. Now, these guys did a very good job. They included more than 10% of patients. In our last nutrition trial, we included less than 5% of all screened patients. So what we find in these trials, it's very difficult to make conclusions. So we certainly need these large-scale pragmatic trials, like the EFFORT trial, which has been designed by our chairman and his colleagues. Now, we monitor nutrition in our ICU, and this is now just some data that hasn't been published. I want to share with you. It's retrospective data of 220 patients in our 39-bed mixed surgical medical ICU. We have a nutrition protocol in place, and we monitor nutrition as we think adequately, but we will see that this is not really the case. So this is now the daily administered nutritional calories. It's the average daily administered calories per patient. You see on the x-axis the length of stay, on the y-axis the calories. What do you think? What is this? I think it's awful. It's really awful. I mean, look at these first 10 days. You have everything up from 0 to 2,500 or 3,000 calories. And it seems that it levels off. It goes to maybe 1,500 calories after 10 days. I have to admit that here we do not monitor, and that's the first thing we learned actually ourselves. We do not monitor what the patients are eating. So that's what we changed now. So there are certainly patients who also eat in addition to their enteral nutrition. So we can assume that we get to a higher number of calories, but still it's not explained why you have this scatter plot. Now we tried to look at different reasons why this could be so weird. First of all, we looked how do we adapt to the weight of the patients, and you see there is nothing at all. So actually in our protocol we say we go up to 25 kilocalories per kilogram body weight, or then to indirect calorimetry results. But as you can see here, somehow we do not really stick to the protocol. Maybe we thought in the older patients they are sometimes difficult to nourish. Maybe that's an explanation, but it is not an explanation. Then we thought maybe it has something to do with the balances. These are now daily fluid balances. we thought that maybe if you are restrictive with your fluids, then you administer less nutrition. But as you can see, there is absolutely no relation between these two. So maybe it's depending on the bowel function. So many patients experience diarrhea. In our last study, it was 60% of patients had diarrhea in our ICU. And here you can see that also there is no relationship. It's actually not so that these patients with a lot of stool events get less nutrition. And I thought I'd do the same thing with the gastric residual volume, but then I found many, many missing values in our records. And then I went back to the protocol, and actually the protocol says that if you deliver the amount of nutrition you want to deliver and you have no problem, then you don't have to measure gastric residual volume anymore. So we cannot be sure, was that an issue or was it not? So that's the next thing we learned, that we actually have to monitor the gastric residual volume even in patients where you don't have a problem with delivering nutrition. Then we thought, okay, we have a lot of transports out of the ICU to CT, to OR, and so on. Maybe that's the reason, but you can see even in patients with many transports out of the ICU, there was not a relationship. So these patients were not the ones who didn't get fed adequately. Then we thought maybe it's the agitated patients. They pull their nasogastric tube out, their feeding tubes, and don't get the nutrition. I took the RAS2 scale because many patients had these measurements, and I was astonished how many actually measurements a day we have for these RAS2 scales. So patients are really agitated. One interpretation is that we don't oversedate them. That's a good thing. But definitely it has nothing to do with difficulties in nutrition delivery. And then finally we thought maybe these are the shock patients receiving catecholamines who do not get nourished, but as you can see, those without catecholamines even got less calories. So I have no explanation for this heterogeneity. Maybe you have an explanation. How do we monitor? What could we make better to explain these heterogeneities? Now that's our patient data management system. The range is now on the x-axis is 1 week. And you see here in the upper left quadrant, you see green, the ordered calories, and red, the delivered calories. And then the brown is the nutritional pump speed. And it's when it goes straight down, that's midday where we do the balance of the last 24 hours. So it's set to 0 and starts again. On the right upper panel, you see the gastric residue volume. Here it was a lot, so it was always measured. On the left lower panel, you see water and glucose delivery and drugs. Here lactulose, and then in brown the stool events. And on the right lower panel, you see the data from indirect calorimetry. And now here, this last week, it looks quite good. I mean, it's basically the ordered and delivered calories, they fit. The infusion pump was running almost all the time. And in these 7 days, we had 3 indirect calorimetry measurements. And there you can see that the measured energy expenditure was somehow adequately reflected by the ordered calories. But now we have also these examples. Now here you can see that during the first 3 days, this patient didn't get an order for calories, for nutrition, and he didn't get any nutrition. And then the next 3 days, he got some nutrition, but without ordering. So the nurses obviously started the nutrition protocol, and maybe they're still today waiting for an order. Then this is another case where you can also nicely see that the nutrition delivery was started, and then on day 4, the doctor made orders. And then the next day, this red column shrinks. So it was ordered, but only half of it was delivered. And the next day, nothing was delivered. So we don't see an explanation for it. There is some gastric residue volume, but it's 260. And in our protocol, it says you can feed up to 500 gastric residual volume. And finally, this one here, you can see that here the first 3 days were okay, then no orders, just a little delivered, and then orders, nothing delivered, and then orders and half of it delivered. And no explanation so far why we have this discrepancy. So the lessons I think we can learn, at least I learned, we should monitor what is ordered and what is delivered, including meals. And I think what we should do is we should monitor it per kilogram of weight per patient. Because it's quite easy to order, 1 bag of nutrition or 2,000 calories. But I think we should really think about what is the weight of this patient, how many calories does he or she need, how much protein does the patient need. And then we should document the gap. We should have an idea what we will do when there's a gap between ordered and delivered. Maybe we accept it, that can be fine. Maybe we just increase the speed of the delivery pump, or then we add parenteral nutrition. Now, I spoke always about the nutritional calories, but there are obviously also non-nutritional calories. As you can see here, in the upper left panels, these were patients with citrate anticoagulation. Right upper panel, dextrose infusion. Lower left panel, patient with propofol infusion. And right lower panel is the all patients together. And you can see that during the first 3 days, patients get a substantial amount of non-nutritional calories. And obviously, these calories, they don't contain protein. Now, we had in our cohort, we had a similar situation. You see here during the first days, you get quite a substantial amount of non-nutritional calories, mainly by dextrose and propofol. And if you look at the ratio between non-nutritional and nutritional calories, you see also that it can be up to 90%. And during the first 5 days, substantial number of patients get between 20 and 50% of their calories by non-nutritional calories. So I think we should think about this. It is an important issue, for instance, in patients which need prolonged sedation. For instance, patients with ARDS or traumatic brain injury, they can be overfed. Or also in patients who receive a lot of dextrose infusion, for instance, when they have liver failure, they should be accounted for when we prescribe nutrition. Now, what is the right amount of protein? The latest ESPEN guidelines, you find there a number of 1.3 grams per kilogram. Interestingly, there is this retrospective study by Arthur van Santen and his group, where he actually looked at patients who received little protein, less than 0.8 grams per kilo per day, and those who received more or a lot. And you see that the lowest or the highest mortality, the blue line, were patients who received little protein, less than 0.8 grams. But the uppermost best line was not patients who received all the time high amount of proteins, but these were patients who received in the beginning a little bit less protein, but then after day 3 they received more proteins. So I think that's actually fits this situation that we have in the first days. We have these non-nutritional calories, and I think we have not to be that much concerned that we don't deliver enough proteins, but then after 3 days, I think we should increase the amount of protein. Now, my conclusions. I frankly think that it's a little bit a neglected fact. We should monitor nutrition better. We should actually do that as well as we do it for hemodynamic monitoring. And as we have seen, there is a large variability in this delivered versus ordered calories, and we should find explanations for this, and we should document the reasons. Then these nutrition protocols, they should include the measures we do when we see these gaps. We can accept them, then we should say, okay, we accept them for these and these reasons, or we should do something against it, and then we should actually help the physicians and nurses at the bedside with a decision. So what should they do now when they can't deliver what has been prescribed? And finally, I think nutrition business in the ICU is left mostly to the nurses, and they do a good job. But I think they should be supported by us doctors. We should help them to deliver adequate nutrition, and for this we need adequate protocols. Thank you for your attention.
Thank you very much. So now let's move to the next speaker.